Hello, I'm Anton Mahmood. I'm talking to you today about skin and hair rejuvenation using the Solenis PRP system. We use PRP in this clinic for hair and skin on a regular basis. I have a research interest in how PRP works, the basic science behind it, and we do lots of in vitro testing, which then I try and translate into research into patients to improve our outcomes. The actual system that we're demonstrating on a 22 ml blood draw, I can usually obtain around 12 to 13 mils of plasma. And the other thing that I really like about this system is, other than the ease of use, is that I can then concentrate that. So if I wish to double or triple, even quadruple my platelet concentration, I can do that using this system, which I can show you later how that's done. But this is the tube. The red cells are concentrated at the bottom below the gel. You'll see there's a mechanical barrier here, and the plasma sits above it. The platelets sit really just above the gel layer, and the rest of this is actually plasma, or platelet poor plasma, which means I can take as much of this out. If you take out around half, for most patients, you end up with around about 4-fold concentration, 4 to 5-fold concentration of your platelets, and that's usually adequate for skin and hair. The exact cell counts and the science behind this is not that well understood by most clinicians, so we'll try and elucidate some of that as we're going along. So I'll come around now and we'll prepare the actual plasma for use. So within the kit, you get all of this within the Solenis kit. It arrives in a box, and there is a filter which is required to be used, which sits between the syringe. It allows, you can see with the stopper on, it allows a closed system, so it's sterile. I use this for both orthopedics and non-orthopedic procedures, with it being a closed system. There's vacuum within the tube, and so sometimes to make drawing out easier, you can use a filter needle, which again maintains a closed system but removes the air. If you just pop that into there, just into the air, it gets rid of the vacuum. I will then use this needle to extract the plasma that I don't wish to use. And you can potentially use all of this plasma for skin indications, because at baseline, if we were to use all of this plasma and resuspend it, you would probably still have around about 2-fold to 2.5-fold concentration, which for most skin conditions, in my view, is probably adequate. I'm extracting approximately 5 mils there. I'll leave the needle and the disc filter attached, and then what we must do is resuspend this, because as I mentioned before, the platelets are sat on top of the gel, and so the resuspension step is crucial to mix your platelets together. And you can see the gel is fairly robust, and it allows fairly vigorous mixing to try and to equalize the concentration of platelets throughout the plasma. And I tend to do this probably at least 20 times, but you can do a little bit less or a little bit more, but I think the more you do, the better. I think you get more equalization of your platelet concentration, and you really want to mop up all of those platelets sitting on the gel and around the bottom of the glass of the tube, which is where we know from research and studies and the manufacturer's guidelines where the platelets are sitting. So once I think I've got the vast majority of them, which we know usually after around 15 to 20, I've done a fair bit more than that, of these washing or rinsing sort of steps, we've resuspended the platelets into the plasma, and you can sometimes note that there is a slight change in the density and the cloudiness of the plasma itself, which probably means it's a little bit more cellular. So once I've got the resuspended plasma, I can now decant it into my syringes. I tend to then decant from the 10 ml syringe into 1 ml syringes, and I use that for actual treatment. And now it's probably a little bit easier to just withdraw your needle back and do it in a retrograde fashion so you can catch all of your plasma without the danger of penetrating the gel if you do it in this fashion. I'll be using this 1 ml Luer lock syringe, and it is important to have a Luer lock rather than a Luer slip, because extrusion force for the technique that we use, which is very superficial and intradermal, do generate quite a lot of force, and it will separate the needle from the syringe. So Luer lock is important. I use this Luer to Luer connector to make it easier to draw the plasma into my 1 ml syringe, and I can transfer that straight across. There we go. So there's 1 ml in there for injecting, and I'll leave that there. And I'm using a 33G, so a very fine needle, because the actual extrusion force of PRP is very low. This is anticoagulated. The anticoagulant within the tube allows you up to a few hours, actually. You can sit there and you can still use it without it thickening or changing in its extrusion force. The properties remain unchanged. The actual anticoagulant in the system is pH neutral. So it's not stingy when it goes in, whereas in others where it can be an acidic anticoagulant, there's more discomfort when you inject it into the dermis. That's a very fine needle. It's also a very short needle, which I prefer for the technique I'm going to be employing. I'll show you that in a moment. So we'll just prepare the patient now. So we'll start with face, and we've already had a local anesthetic cream applied to the skin for the last half an hour. I recommend half an hour to 45 minutes for the best effect. So we just prepare the skin now, do antiseptic preparation, and then go on to do the injection. Sam's had this treatment before, so she knows what to expect. Obviously take your normal informed consent for patients, but overall this is, compared to many other aesthetic procedures, it's actually a very safe procedure with minimal downtime and minimal side effects. Especially with the technique we'll be showing you that we employ. The other beauty of PRP treatment is that actually the substance itself, the plasma, has antibacterial properties, and that's been proven. It resists biofilm. The technique we use is very superficial for injecting. What I try to do is aim for as superficial as you can. So you're aiming for above the epidermal dermal junction, which in some areas, particularly around the eye, can mean much less than 1 millimeter of depth, which can be quite challenging. In other areas where you've got thicker skin, lower down in the face or the forehead or around the nose, that can be a little bit easier. I can show you a picture of the relative thickness of skin to the bevel of the needle, which we can demonstrate to you the difference. But it can be quite a challenging technique. But to me, if you want the best results for freshness and improvement of pigmentation issues in particular, which is one of the commonest reasons people come to see you, then you've got to aim for that layer. Otherwise, you will miss some of the melanin-producing cells, and you don't get the best results. So just starting. So the technique, you've got some sharp scratch coming. You've got to have a short working length. So injection in, and you raise a nice little bleb, which hopefully you can see there. And it generates quite a lot of resistance. I'm so superficial. I'm not actually getting very much in there, and I'm working that. I've just about got 0.1 of a mil, and you can see that nice white bleb, and I can feel it, it's nice and firm. And you do that in steps, so that will give you, that's going to diffuse over about a centimetre and a half. So your next injection site, depending on the area you want to treat, is going to be about a centimetre and a half away. Some people prefer to draw grids. I just tend to carry on with this now with the eye of experience, I suppose. I don't do grids any longer, but I did start off with that. And again, as superficial as you can. You can sort of see the placement of the needle. You should feel quite a lot of resistance to your injection. If it's going in very easily, you're probably too deep. And again, quite a lot of resistance there. And you keep working until you get approximately 0.1 per bleb. So you can work out roughly that if you've got 6 or 7 mils of plasma, you're going to get approximately 60 or 70 injection sites. For hair preparation, it can be a little bit more challenging, obviously, particularly with ladies with long hair. So you can use a chlorhexidine-based shampoo the day before, which is something. Sometimes I recommend that. You don't tend to treat on the day you see a patient, so you can usually get them go away and they can do that. But then you can use a combination of chlorhexidine on the day, along with witch hazel, which I use to wet the hair, and it allows you to, once your hair is wet, you can separate out a target area and then move along. Again, the grid-like pattern continues, so you're placing about a centimetre and a half apart the injections. There's some controversy around depth of injection. I know traditionally dermatologists and trichologists aim for the hair follicle. The hair follicle normally sits around about 2.5, 3 millimeters depth, possibly down to about 4 millimeter depth. So in the dermis, my view is that actually, again, you should be aiming superficially. You should aim for a 1 to 2 millimeter depth injection at most. So you're above that area, and part of the reason for that is that the hair bulges above that area, which we know now from more recent research and work is where the stem cells sit. And so if you really want to stimulate the follicle, you've got to hit that target area. And whatever you diffuse down doesn't tend to come back up again. So my theory is that if you want to stimulate that whole area, you've got to start above it, and the diffusion occurs downwards through the cell lines. So we, again, similar technique, you raise the white blebs. And we know that it only works on active follicles. So you have to have living follicles. So if somebody has no active follicles, this treatment is not the right treatment for them. But what it does do, and it's been shown fairly conclusively now, is that it will stimulate the follicles that are there. So a follicle, for instance, that generates 2 hairs will generate 3. Overall, it seems to suggest around a 25 to 30% increase in density of hair, and around about a 35 to 40% increase in the thickness of hair as well. So you get more hairs per follicle, and the hair itself is thicker. And part of that is because it actually increases the anagen, the growth phase of the hair. That's the pathway. So the hair is growing for longer. Hair retention is higher. The hair is stronger, so actually resists being pulled out more. And again, that's been proven in some of our studies. So a vellus hair, it will thicken and it will retain. But again, you manage your patient's expectations here. It's what I tend to do is I describe this treatment as hair resuscitation rather than restoration or rejuvenation. It's improving what's already there. So we'll start just here on the hairline for Sam, and again get a good anchor point, superficial, about 1 to 2 millimeters in, and I'm raising a bleb. Again, quite a lot of resistance. Same volume, about 0.1 per bleb. There we go. So you can just see there, the white bleb just on the edge of the hairline. It's palpable, visible, and you want to repeat that now in the area of concern. So here, So I'm a slightly vellus hair here, thinner, so we're going to be going along here and raising those in a grid-like pattern again, 1 to 1.5 centimeters apart, and we'll complete that area of treatment. So again, you can imagine if you're doing a large scalp, you're going to need probably more than the 60 or 70 injections this may give you. For hair, I think it's much more important that you concentrate, and that's what the evidence tends to suggest that you probably need at least 1 million platelets per microliter, which usually in most people with an average blood count of something like 150 to 250 or 300 platelets per microliter needs a concentration of 3 to 4-fold at least. So I tend to concentrate up to 4 to 5 times in my practice, which generally means I end up with around about 4 or 5 mils of injectate from the 13 mils of plasma, which usually does mean I need more than one syringe, more than one tube. So I usually use 2 tubes of the 22 mil for hair. In my practice, the 22 mil tube has become pretty standard. I use it for orthopedic and aesthetic procedures, and I actually use the 11 mil tube less and less frequently. So carry on. So about 1.5 centimeters away, 1 to 2 mil depth. We are in the process of designing some research studies looking at our technique in collaboration with the British Association of Hair Restoration Surgeons, who are willing to collaborate with our work on this area. You can get a little bit of backsplash, particularly from open pores, so using eye protection is probably quite important. So I've demonstrated to you the technique which I go through in some of the courses I run in a little bit more detail with the anatomy, but in essence aiming very superficially. Epidermal dermal junction I think is absolutely key to getting a result. One of the things I found when I was training people who had been trained in other centres was they were losing faith with PRP because their results were so variable. And what we found is that with the technique that we use, our results are actually very reproducible. And particularly with this system, if you're going to use a system within a clinic and you're new to a system, you want something simple. You want something simple and versatile. And that's what Sunny's given me. It's given me an 11 mil or a 22 mil tube, which I've already said I prefer the 22 mil tube because from an efficiency point of view, from 22 mils of whole blood draw, I can end up with about 13 mils of plasma, which is actually a very large quantity. If I'm using that for the face, I can use it entirely, so I can use the whole 13 mils, which will do a full face with one tube. If I want to use it for hair, I can concentrate that, and I can concentrate that if I really want to up to around 10-fold, because I can just have 1.5 mil of injectate for a problem area and remove all of the platelet-poor plasma, because as I said earlier, when we mix this, the vast majority of the platelets are sat right on top of the gel in the bottom, half a centimetre or so of the tube. So you can remove plasma right down to up to leaving 1 to 2 mils of plasma behind for your injection and still have all of your platelets sitting in there. It tends to give you a yield of between 80 and 90%, so it retains 80 to 90%, which is a very high efficiency for collecting the platelets from the whole blood. It's got this gel which gives you a mechanical separation, so your chance of error or contamination of the red cells is very low. It gets rid of, this is a leukocyte poor plasma, because it gets rid of 90% plus of your catabolic granulocytes, which can generate inflammation. Inflammation, certain indications is important, but certainly I think in the face and the hair you want to minimize inflammation. In orthopedics for joints you also want to minimize inflammation, so it's a very versatile system for multiple indications. It selectively retains, interestingly, the monocyte population, and what we're starting to see now with more and more research is that monocytes are very good at stimulating local stem cells and increasing the response of growth factors. That's the reason that I prefer to use Solenis PRP for this particular indication, and I'm happy to take any questions if you have them.